All right, and that's 7 o'clock. Good evening, everyone. My name is Christopher Schroeder. I am a professor of anesthesiology at the University of Wisconsin, and I am incredibly pleased to welcome all of you here tonight to the ASRA Pain Medicine Hot Topics webinar presentation on compassion and care for the LGBTQ plus patient and colleague. We have an amazing panel here tonight, starting with Dr. Paul Su from the University of California in San Francisco, who will be discussing preoperative considerations for the LGBTQ plus patient, followed by Dr. Elliot Higgins from the University of California, Los Angeles, who will discuss treatment of LGBTQ plus colleagues. Dr. Olga or Kiki Nin from the University of Florida in Gainesville will then discuss understanding pronouns. And finally, Dr. Hamza Ramawad from New York City Health and Hospitals Incorporated in New York will discuss surgical procedures and regional anesthesia techniques that may be relevant for our LGBTQ plus patients. Along the way, we're hoping that this is something that can be incredibly interactive. I know that this is something that can generate a lot of questions. And so please, if you have any questions, please type those questions in the small Q&A text box at the bottom of the Zoom program. And when you're finished typing in that question, hit send. At the end of the entire presentation, so we'll let all the presenters kind of finish up with their content. We'll then go through and answer as many of those questions as we can get to. Please note, of course, that we may not be able to get to all of them, but we will get to as many as we can, and getting your question in early will help get it on the slate. So without further ado, I will turn things over then to Dr. Paul Su.
Thank you, Dr. Schroeder, and thank you for the invitation. It's really exciting to be able to talk about this topic that's really near and dear to my heart. And so, again, my name is Paul Su. I'm an assistant professor at the University of California, San Francisco. And in the next 10 minutes or so, I hope to kind of share with you some of the specific perioperative needs and anesthetic risk factors that are commonly faced by patients within the LGBTQ community or the sexual and gender minority population. I have no conflicts of interest to disclose. And just as a way of introduction, approximately 4.5% of the US population identifies as being a member of the LGBTQ community. And kind of throughout history, there's been series of societal, institutional, historical stigma and discrimination that has led to kind of a lot of mistreatment in the past, and has resulted in many LGBT patients fearing that coming out to their healthcare providers may result in inferior care. In fact, there's been demonstrated health disparities within the sexual and gender minority population that I've included here in the slides. Just to name a few, for example, LGBTQ individuals are at an increased risk for depression, anxiety, suicide attempts, substance use disorders, smoking, high-risk sexual activities. And as you can start to see when you're planning an anesthetic plan, some of these health disparities start to kind of float to the top as issues that may impact one's anesthetic plan, and as well as the patient's anesthetic risk. As Dr. Schroeder alluded to, Dr. Nin will spend some time in her section discussing the use of pronouns, the importance of pronouns. But here I just want to mention that it's really important for anesthesia providers to take on a very welcome, open, and respectful way to make sure that the LGBTQ patients do not feel discriminated against. And one of the easiest ways to accomplish this is to use neutral language, do not assume any gender conformities, and to really allow the patient to kind of disclose and use their preferred pronouns when interacting with the anesthesia provider. One thing to note is that most often LGBT patients will undergo a surgery that's completely unrelated to their sexual orientation or gender identity as well. In addition to the usual assessments of the different organ systems as they relate to the anesthetic risk, there may be particular special considerations for patients in the sexual and gender minority group. Specifically, hormone therapy is something that can be is commonly used within the transgender and non-gender conforming patients, and often they are on this long term. There's two kind of main classes of hormone therapies for gender dysmorphia or gender expression. There's kind of the feminizing hormones, which is usually a combination of a testosterone blocking agent such as finasteride or spironolactone, as well as estrogen replacement. In particular, I've highlighted estrogen here, especially oral formulations of estrogen that can have a significant impact because oral formulations of estrogen has been associated with possible increases in venous thromboembolic events due to an imbalance of anticoagulant and procoagulant factors. And so when this is coupled with other risk factors such as cancer, smoking, it may warrant a change in the anesthetic consideration to evaluate for potential pharmacologic DVT prophylaxis, for example. Usually, it's not necessary for patients to be on hormone therapy to interrupt their hormone therapy for surgery. However, some surgeons may advocate for discontinuing hormones for a couple of weeks leading up to surgery. While this is not dangerous, it may cause kind of emotional or physical effects, such as the withdrawal of the gender features, which may be distressing for patients. So it's something of note for the anesthesia provider. Pregnancy testing is also something that comes up quite frequently when taking care of the LGBTQ community. The ASA recommends that all biologic women within childbearing age be offered pregnancy screening, especially if the results of such screening would change the course of medical management. While there is not a single best way to ask for pregnancy, there are some kind of guiding principles. First is that patient report is extremely unreliable, and that's why we offer pregnancy tests. Additionally, an extra layer of complexity is that patients in the LGBT community may not know their own fertility capabilities. For example, there's a very common misconception that oral testosterone for hormone therapy can replace contraceptives, which is not the case. It can be helpful to have system-based policy practices to offer patients capable of ovulation who have sex with sperm-producing partners the option for a pregnancy test. But another important point to keep in mind is that patients should not be forced to undergo pregnancy testing. As I've alluded to previously, a common health disparity among the LGBT population is HIV and sexually transmitted infections due to high-risk sexual behaviors. There's no set guidelines for routine preoperative lab testing, and the approach to the perioperative assessment for patients with HIV is the same whether or not, regardless of their LGBTQ identity. The topic of antiretroviral therapies as well as HIV is a totally separate kind of can of worms in terms of some of the considerations. But in general, the thing to note is that antiretroviral therapies and opportunistic infection prophylaxis should be continued throughout the perioperative period. And that's because cessation of ARTs can result in rapid viral load rebound or immune decompensation. So when you're considering surgeries where patients may have a prolonged NPO status perioperatively, it is best to consider consultation with HIV specialists for possible HIV resistance patterns locally, as well as potential solutions to find parenteral replacements for ARTs. Providers should also be familiar with the multi-organ effects from HIV, as well as the effects of ARTs, such as cytochrome P450 inducers, inhibitors, which may have an impact on drug-drug interactions. Now, in the last couple minutes, I also want to touch on some of the anatomic considerations which may be encountered in this LGBT community, specifically some of the airway considerations. The airway anatomy reflects a biologic sex and not the phenotypic appearance of the patient. And this is especially important, for example, after facial feminizing surgeries, for example, where there may be a relative micrognathia from reduction of the angle of the mandible. There may be post-surgical scarring after feminizing surgeries, which may make mask ventilation and possible intubation more challenging because of the reduced range of motion. Laryngoplasties, chondroplasties, and other functional voice surgeries may increase the risk of endotracheal intubation, especially increasing the difficulty of intubation, increasing the risk of vocal cord damage, perforation, and tracheal stenosis. And then lastly, sometimes after surgery, the landmarks that we rely on for procedures like emergent cricothyrotomy may be distorted as well. To summarize, the care of LGBT patients can be straightforward as long as the provider approaches these patients with cultural humility. It is otherwise not much different from taking care of patients from other cultural or minority backgrounds. So here are some references. I want to draw everyone's attention to two kind of organizations that have been really prolific and really helpful in providing guidance to anesthesia providers and just healthcare providers in general in working with transgender patients. And one is the World Professional Association for Transgender Health, and the other one is the UCSF Transgender Care as well. Thank you.
All right, everybody, it's Elliot Higgins here. For our Azure team, I'm having trouble turning my video on. If someone could help me so I can be enabled to turn my video on, that'd be great. Excellent. Can you all see me? I think you can. Perfect.
Yep, can see
Excellent.
it.
We're cruising. Elliot Higgins here. It's a pleasure to be here. Thank you, Dr. Sue, for that awesome overview. I'm the Director of Health and Wellbeing at UCLA Department of Anesthesiology. We're going to be switching the lens a little bit here and talk for a few moments about caring for the LGBTQ plus healthcare provider. I don't have any disclosures, and just jumping right in, we're going to go over a few things. We're going to go over why shine a spotlight specifically on caring for this population, that being the LGBTQ plus anesthesiologist or healthcare professional. We're going to review some data on LGBTQ plus healthcare professionals and anesthesiologists. We're going to go over some strategies for supporting unique populations in general. I'll leave you with some specific advice and thoughts on areas that are in need of future investigation, frankly, and I'll leave you with some recommended resources. I do want to point out this information is really relevant to teams at all levels, and I do think that includes regional anesthesia and pain medicine teams. My hope is that this talk will inspire those of you on here to think about how you can create a culture of well-being, which includes a culture of belonging and a culture of acceptance on the RAPM teams that you are a part of. So this is going to be a bit of data up front. What I'm trying to focus your attention on is trends across LGBTQ plus employees. Let's start with anesthesiologists. So simply put, the data tell us that LGBTQ plus individuals are at increased risk for burnout, and this includes anesthesiologists. This is a 2021 fairly landmark paper published in Anesthesiology using the Maslach burnout inventory. Afonso et al. Published data demonstrating that nearly 60% of anesthesiologists are at high risk for burnout, and roughly 14% actively met criteria for burnout syndrome. Last month, a follow-up paper for this was published, and the numbers are actually a little bit more impressive now. But importantly, in this paper, there were 4 risk factors for being at high risk for burnout that were identified: perceived lack of support at work, working greater than 40 hours per week, LGBT status, and perceived staffing shortages. I'm going to go ahead and highlight this. I want to bold, italicize, and underline this. LGBT status is a unique risk factor that predicts whether or not an anesthesiologist in the United States is at high risk for burnout. And that's a really big reason as to why we're talking about this tonight. What do we know about the stressors that LGBT plus healthcare professionals face? Or to put that a slightly different way, why could it be that LGBT plus status is a unique risk factor for burnout? When it comes to specific stressors for LGBT plus anesthesiologists, this is one of those areas that's frankly in need of future investigation. But let's zoom out and talk about healthcare professionals broadly for a moment, just for some insights. This is Coping with Stress as an LGBTQ plus healthcare professional. This is from a 2018 publication in the Journal of Homosexuality. 277 healthcare professionals were surveyed. About half of these were physicians or advanced practice professionals. 38% reported not being out in the workplace. 35% reported that well-intentioned coworkers made stereotypical comments or microaggressions. And there was an overall perception of discrimination. Of the 62% who were out at work, 41% confirmed that being out has caused them problems. What kind of problems? Discrimination broadly, refusal of tenure, harassment, delay of academic promotion, change of jobs to escape prior discrimination. So we can see that there really is widespread fear of being out or feelings of discrimination among healthcare professionals. Now, reassuringly, of this sample, the majority of healthcare providers used healthy coping mechanisms. This study didn't just look at things like not being out in the workplace. This study also looked at the coping mechanisms of the healthcare professionals who responded. And reassuringly, we're a resilient cohort. And this really tracks with data we see about healthcare professionals broadly. We are a resilient cohort. And I think it's important to point out, because what this points to is that this isn't some sort of unique flaw within the individual LGBTQ plus healthcare professional. This is not about a lack of resilience. This is not about a lack of grit. And this is why, in my opinion, the best path forward is efforts that are really rooted in systems change to create supportive environments for our LGBT providers. But we'll talk about that more in just a little bit. Let's turn our focus to trainees for a moment. Anesthesiology trainee-specific data is another area that's frankly in need of future investigation, but we do have some data on surgery residents. This is from JAMA Surgery, Experiences of LGBTQ plus residents in U.S. general surgery training programs. About 7,000 clinically active surgery residents across the U.S. were surveyed. 4.8% identified as LGBTQ plus, and those LGBTQ plus respondents reported higher levels of mistreatment and were 2 times as likely to consider leaving their program or have thoughts of suicide. And again, I think it's important that we as a RAPM community are aware of this data and these trends so that we can work to foster supportive educational environments for our regional anesthesia and pain medicine trainees. What about one more level of granularity? We've talked about anesthesiologists, we've talked about healthcare professionals broadly, we've talked about residents. What about medical students? When it comes to the relationship between sexual orientation and burnout and mistreatment, we have this data. This is a 2021 JAMA article published by Samuels et al. Cross-sectional surveys, 2016 and 2017 data from the AAMC, and they found significantly higher rates of perceived mistreatment among lesbian, gay, and bisexual medical students as compared to their heterosexual counterparts. Those lesbian, gay, and bisexual medical students had an increased odds for burnout, and those LGB medical students who did report sexual orientation-specific mistreatment, that specific cohort had an 8-fold higher predicted probability of developing burnout. And so again, we see fairly pervasive reported encounters of mistreatment, increased risk for burnout, and of those who do encounter mistreatment, especially high risk for burnout. Let's zoom all the way out. It turns out that the trends we've been discussing in healthcare aren't unique to it. This is a wonderful data set from the UCLA Williams Institute. I just want to highlight this briefly. 2021 assessment of LGBT people's experiences of workplace discrimination and harassment. Just as some context, there are over 8 million workers in the US who identify as lesbian, gay, bisexual, or transgender. And in 2021, the Williams Institute surveyed roughly 1,000 of those people. They asked about lifetime, 5-year, and past-year discrimination, and what they found is that 45+% of U.S. lesbian, gay, bisexual, and transgender workers reported experiencing unfair treatment at work, and they reported that this is ongoing. Nearly a third reported harassment within the last 5 years. Okay, so big picture, this data tells us that employment discrimination against LGBT people continues to be persistent and widespread. All right, so we've established LGBTQ plus employees, including anesthesiologists, throughout medicine broadly, have some threat to their well-being, have higher levels of mistreatment and discrimination when compared to the cisgendered heterosexual counterparts. And I think that this data and these trends are relevant to our RAPM team. So what do we do about this? Very, very few studies have examined how different workplace interventions may mitigate these disparities, but I've already shown some data telling us that LGBT employees demonstrate healthy coping mechanisms. So again, I would suggest the problem doesn't lie within the LGBT individual. Again, I suggest that we need to focus on efforts working to make our workplaces as supportive and as inclusive as possible. We need to focus on fostering supportive environments. This is all about belonging. One big way to demonstrate inclusivity and create a sense of belonging is via visibility. And I'm going to show you some simple examples of how organizations like ASRA and teams like your team perhaps can facilitate belonging via visibility. And this webinar, frankly, just to get really meta for a moment, is a prime example of something good that can be done. Just having these conversations is important. But there is some data we can look to for evidence-based initiatives. Let's start there. This is a neat study, 2022. Perales published this in Preventative Medicine. I'm going to cut to the end here just in the interest of time. They used a regression model analysis to demonstrate that essentially there are two, per this study, data-supported interventions to enhance LGBTQ plus employee well-being. Number one, workplace gender and sexuality diversity trainings. These are trainings that aim to sensitize the workforce about human diversity with regard to gender and sexuality, introducing key concepts like heteronormativity, homophobia, unconscious bias, and describe in detail the challenges that specific minority populations can face in the workplace. The other intervention are ally networks. These are employee networks, sometimes called outlets, and when we're talking about LGBT-specific networks. These are formal or semi-formal internal groups of employees specifically established to create respectful and inclusive workplace cultures. This is one example in healthcare. This is a massive effort from UCSF. This is their outlist. This is an enterprise-wide initiative aimed at fostering visibility and awareness for all UCSF LGBTQIA plus students, staff, faculty, residents, postdoc, fellows. But an outlist doesn't have to be such a big effort to create community. Here's something that we're doing here in my department at UCLA. This is the LGBTQIA plus initiative in the Department of Anesthesiology and Perioperative Medicine. This effort was launched last June during Pride Month. We planned all sorts of activities, mentoring opportunities, LGBTQIA plus health educational forums, various avenues to support. We created a listserv, which is for now acting as our form of an outlist. We worked the well-being program, work with the Justice, Equity, Diversity, and Inclusion program to raise awareness to LGBTQ plus allyship trainings, all sorts of events to really foster a sense of community. While some of those efforts may be more department-wide or department level in scope, there are some things that can be done at the level of the regional anesthesia and acute pain medicine team. One of those is a physical sign of support, like a pin. This is a pin that we made in our department. It's honestly really exciting when I see these all around our perioperative spaces, on people's scrubs, on their backpacks. You can make lanyards. There are very simple steps you can take to demonstrate solidarity and visibility. Another thing you can do are public messages, such as tweets or emails. Little things like that can be incredibly helpful to foster a culture of belonging. At the level of a health center, an institution can do something like this, which UCLA Health did. This is a screensaver that says, we provide compassionate, inclusive, and equitable care for our diverse LGBTQ plus community. Personally, as an LGBTQ plus anesthesiologist, just seeing this around casually definitely makes me feel more included, enhances my personal sense of belonging. A relatively small, in terms of mechanism, relatively small effort by an institution to help teams of individuals feel like they belong. At the national level, calling out biases that LGBTQ providers may face can help. ASA has done this. I was extremely excited when Azra during Pride Month put out this tweet, and I'm very excited that the LGBTQIA plus SIG is working to get things like pronoun badges at the national conferences. These seemingly small things really can make a big difference for our LGBTQ plus colleagues. Okay, so just to wrap up here, I want to leave you all with a few key resources in addition to what I've presented thus far. These are some of my go-to resources when it comes to this work and having these conversations. Number one, this is a fantastic reference from Doctors Rees-Wynn et al. Burnout, mental health, and workplace discrimination in LGBTQIA anesthesiologists. The QR code is there. I highly recommend you take a moment, scan it, click it, save it. This is a fantastic reference, and I can't recommend it any higher. When it comes to creating inclusive spaces specifically for LGBTQ plus individuals, these two books are fantastic. In these books, Dr. Adam Brett, Joe Brassington, and Sean Valenti describe their efforts at fostering LGBTQ plus educational spaces. These books are intended to teachers. But I find that they're deep dive discussions, but I find them very relevant to the work that I do in my workplace. And I find that much of what they talk about and write about has translated really well to my workspace efforts. Well beyond the scope of this talk to go into this in significant detail, but these books go over how to set the scene locally, how to create a strategic vision, how to implement change. And again, the hope of all of this is to foster a sense of belonging and mitigate burnout. So, wrapping up here, LGBTQ plus healthcare professionals are at a unique risk and they are worthy of our attention. This is especially true for our transgender and gender diverse colleagues. And the question that I ask myself when thinking about this work and that I would like to leave you all with is how can we make our workplaces as supportive as possible? I'm going to end with this quote. This is a fantastic quote from Kaylin Dion. This is interpreted by the artist Leo Gawana. The QR code goes to the artist's website. This is shared with the artist's permission. Encouraging someone to be entirely themselves is the loudest way to love them. And with that, I'm ready to pass the baton.
Good evening, everyone. Are you able to see my slides? Let me go back.
Yep, I can see them, but I can see the presenter mode side slides as well.
What about there?
Perfect.
Perfect. Well, thank you very much all for joining. Thank you, Elliot and Paul, for a wonderful presentation. I'm Kiki Nin. I'm an associate professor and the assistant chair of clinical affairs over at University of Florida in Gainesville. Thank you very much, Chris, for inviting us. I'm going to talk a little bit about why gender pronouns matter. So I know Paul mentioned it, but I wanted to put it a little bit in perspective. So how many people are we really talking about? There was a survey done in 2022 that said 70% of Americans identify themselves as lesbian, gay, or bisexual. Just to put it in perspective, from the census of 2022, that is 23 million Americans. Also, there's 1.6% of U.S. adults identify themselves as transgender or non-binary. So that is 5.3 million Americans. So this is a significant impact that we can have to our patients and our colleagues. So how are LGBT patients unique? You know, I know we've been talking about this, but you know, it's incredible to think about that 47% of LGBTQ people report that they have different health conditions and are regularly in regular care and using medications, and 36% of them report negative experiences with their providers. As you can see here as well, this was a survey that was done in 2020, and it shows that LGBT patients report higher negative experiences compared to the non-LGBT adults. And in things like, you know, saying that healthcare providers didn't believe that they were saying the truth, suggested that, you know, personally they were to blame for their healthcare problems. They assumed something about that patient without even asking them, or dismiss their concerns. So these are very, you know, important things and that we should be addressing with our patients. So let's talk a little bit about, you know, kind of terms and pronouns. What does LGBTQIA stand for? So that's lesbian, gay, bisexual, transgender, queer, questioning, intersex, and asexual. Some additional terms that you will, be encountering are some of the above. Agender are people who do not identify themselves as having any specific gender. You can also have bigender patients who identify as both male and female. You can have non-binary patients who, encompass any gender identity. It does not fall between the male or female gender binary. So what are pronouns? Pronouns are linguistic tools, right? That you and me use, that we use to refer to people, such as they, them, she, her, he, him. They're an integral part, to who we are. And we share pronouns because we want to avoid someone's, pronouns being based on factors, such as appearance. You're going to see common pronouns such as she, her, he, him, they, them, but there are also other non-binary pronouns. Mary Emily O'Hara, an officer of GLAAD, mentioned that pronouns are basically how we identify ourselves apart from our name. For example, my name given by my parents is Olga Nin, but I identify myself as Kiki. So it's how someone refers to you in a conversation. And when you're speaking to someone, it's really simple way to affirm their identity. This can really truly show that you see them, you affirm them, you accept them, you love them, right? They are accepted. And we can ask, our patients when we introduce ourselves, what pronouns would you like us to use? How would you like me to refer to you? How would you like to be addressed? These are the very important, just the first 30 seconds of you introducing yourself to the patient in a very vulnerable and a very delicate, point where they're having surgery and they're scared. So what is appropriate communication? We got to learn and use correct terminology, right? We got to really understand what, gender, pronouns, and their chosen name is. We want to feel comfortable, referring to our patients by their pronouns or their chosen names. And if we make a mistake, we apologize, and move on. We want to make sure we don't make hetero or cis normative assumptions, avoid using heteronormative or gender stereotypical questions. And I'll have some examples of those soon. And just like Elliot mentioned, be a persistent advocate. Ensure all your perioperative staff are aware of the patient's pronoun. In our institution, we use EPIC as the electronic medical record, and we have been able to include, the pronouns or the chosen name of someone in the medical record, very visible, so that everybody who's going to be taking care of the patient can see that, first. And, find ways to improve your personal and organizational care of your LGBT patients and colleagues, just as Elliot mentioned. Why our names are, names and pronouns are not trivial. Just like we mentioned, there's data that's shown that youth who attempted suicide, much higher if they weren't respected, weren't named, used by their own pronouns. And transgender youth, allowed to use their own chosen name, showed a decrease in depression and a decrease of 29 to 56% of suicidality. So this is very important. So just like I mentioned, what if you make a mistake, right? Well, we want to do our best to use, someone's correct pronouns. We make mistakes, we're humans. But if that happens, it is best to just apologize, say the correct pronoun, and move on. Don't dwell on it and make the situation more awkward. So all of our staff, should receive training in LGBTQ affirmative communication. Communication training is essential, not only for physicians and nurses and NPs or PAs, but also for all of our non-clinical staff that interact, with the patient during the healthcare encounter. Examples of inclusivity language are, instead of saying guys and gals or ladies and gentlemen, you can use colleagues, team, people. Instead of referring to just maternity and paternity leave, refer to as parental leave or parental time off. And refer to other people as partner, spouse, significant others. It's a very important, and easy steps to take. Again, we want to encourage a growth mindset, and we want to inspire others to show respect and inclusivity in our environment to patients and to our colleagues. Thank you very much.
Thanks to the presenters who presented so far, and thanks for allowing me to use this platform to wrap up the last section. So my name is Hamza. I am currently finishing up my emergency medicine residency at South Brooklyn Health and soon to be Pain Fellow June of 2024 at Ochsner Clinic Foundation. Now, I'd like to start by saying, gender affirmation surgeries have become increasingly recognized as an important aspect of medical care for individuals in the transgender and the LGBTQI community. And I hope that we're able to leave here today with somewhat of a basic understanding of the terms that we've learned so far in order to provide inclusive care. Now, for some definitions, what is transgender affirmation surgery? These are surgical procedures or a series of procedures that alters a person's physical appearance and sexual characteristic to resemble those associated with the gender they identify with. And these surgeries fall into two main categories. The first being male to female, and the second being female to male. I'm having a hard time swapping my screen. I apologize. Sorry. And so the procedures for these categories can be further subcategorized into top or chest surgery or bottom or genital surgery. Now, to give you an understanding of what this is, top surgery involves the removal of the breast tissue for a more masculine appearance or the enhancement of the breasts or shape or size for a more feminine appearance. And bottom surgery refers to the reconstruction of the genitalia. Now, for these surgeries, they come in several forms and are performed by specialists in the fields of gynecology, urology, and plastic surgery. And quite often it involves a multidisciplinary approach. Now, for those individuals transitioning from female to male, there are various procedures that are available, some of which are highlighted on this table and color-coded based on the specialties. I won't really delve into each one in detail, but it is worth noting that mastectomy is the most common female to male gender reassignment surgery. Facial masculinization surgery is another aspect of the female to male transition, and it essentially encompasses procedures like rhinoplasty, cheek augmentation, jaw contouring to enhance the masculine features of the face. Hysterectomy and oophorectomy is another common choice for many female to male individuals. However, it is important to note that some may opt to preserve the option of pregnancy and childbearing. Now, for individuals transitioning from male to female, breast augmentation and facial feminization surgeries are the most common procedures. And in order to achieve a more feminine facial appearance, trans women may choose procedures like eyebrow reduction, thyroid cartilage reduction, rhinoplasty, forehead contouring, and cheek augmentation. Some transgender women may also opt for bottom surgery, which is a complex procedure involving the removal of the genitals and a creation of a neovagina. Something I would like to note here is that the complications associated with these surgeries are comparable to those of any other surgical procedures. and the rates of complication are similar to those experienced by cisgender individual undergoing similar procedures. When it comes to treating the post-operative pain, and in some cases, the chronic pain related to gender affirmation surgery, the approach is often multimodal, and the selection of pain management methods really depends on several factors, such as the type of procedures done, the patient's preferences, allergies, and sometimes recommendation by the primary surgical team. And what we've seen in recent years is that there's been a notable shift towards adopting a multimodal opioid-sparing approach. Now, taking into consideration the adverse effects of opioids, especially in the context of the opioid epidemic, this approach includes the incorporation of non-opioid analgesics such as NSAIDs, acetaminophen, topical creams such as lidocaine and capsaicin, and regional techniques such as nerve blocks, epidural injections, and intrathecal medication. There are some providers who may choose to add on adjuvant therapies such as ketamine, antidepressants, and gabapentin. And certainly if there is a need for opioids, a stepwise approach should be implemented, similar to the analgesic ladder put forward by the WHO, or whatever policy is frequently used at your institution. Now, given the focus of ASHRA is regional anesthesia and pain, I'll briefly touch upon some of the regional techniques that are available for gender-affirming surgeries. I won't go into each technique in detail, but I do encourage my colleagues who have more experience in this field to jump in at any point. Now, in general, top surgeries are frequently conducted for both male to female and female to male individuals. And some of the regional techniques that can be used are thoracic epidural, paravertebral nerve block, intercostal nerve blocks, pectoralis nerve block, and the delivery of medication intrathecally. These are some of the interventional options that are available. And what I would like to point out is these regional techniques are often done in conjunction with general anesthesia, oral medication, IV medication, or a combination of any of these. Now, for bottom surgeries, the techniques that are utilized, such as epidural injection and erector spinal plane block that can be used, are done in the lumbar and sacral area. I'm just going to quickly give a brief summary of some of the regional techniques that I'm familiar with and some of the stuff that I've researched for this talk. Now, blocks such as the paravertebral nerve block is a unilateral block of the spinal nerve as it exits the intervertebral foramen and provides analgesia spanning 3 to 4 dermatomes and can be done at any vertebral level. The intercostal nerve block is a superficial regional technique that can be done with the guidance of ultrasound. And this block essentially blocks the sensation from skin and subcutaneous tissue of the thoracic wall after top surgery. The pectoral nerve block 1 and 2 is a technique for blocking the pectoral nerves, the intercostal nerves 3 to 6, the intercostal brachial nerve, and the long thoracic nerve. And this block provides analgesia for various anterior thoracic wall surgery, with breast surgery being the most common application. And finally, one of my personal favorites, the erector spinal plane block, in particular, when done in the lumbar or sacral area, can be used for bottom surgery in conjunction with general anesthesia. This block is an interfascial plane block, and it provides a combination of both somatic and visceral analgesia by blocking the dorsal and ventral rami of the spinal nerves. One advantage of this block that we like in the emergency room, it's its extensive craniocaudal spread of the local anesthetic, making it particularly effective for blocking multiple dermatomes at a time. Now, to put some of this in context with some recent literature, there has been a recent meta-analysis published earlier in this year looking at the efficacy of regional techniques for gender-affirming surgeries. And what they found were there were reports of lower pain score and decreased opioid requirements post-operatively when done with the application of nerve blocks compared to cases that were done without. And finally, I'm going to end by saying gender-affirming surgeries are safe, they are effective. There are still many gaps in the literature, and I think platforms like this at ASRA really allows us to make progress. And lastly, one key benefit that I would like to mention is the improvement of mental health outcomes. Individuals who underwent gender affirmation surgeries reported a significant reduction in symptoms of depression, anxiety, and suicidality. That's it for me, and thank you very much.
All right. Thank you all so very much. I think this was absolutely outstanding. And I think something that, not just anesthesiologists, certainly not just those who focus in regional anesthesia, but really anyone who, provides care for patients is going to be able to take something away from this and really kind of improve their ability to care for those patients and then also interact with the colleagues that they work with on a day-to-day basis. For those of you listening, please, again, the Q&A function is available. Go ahead, put a question in there. You're kind of running out of time, so work to get that in there quickly. But first question here, say you have a patient who is, treating one of your colleagues poorly, right? So is not respecting them for, their gender identity or any other aspect of their self. How would you interact with that patient on behalf of your colleague to kind of interrupt that behavior and make sure that your colleague isn't suffering any sort of mental harm? I think I'll start with you, Elliot, and then certainly the group can kind of take off from there.
Can you just repeat the last half of the question? I lost the second half.
Oh, sure. Just you have a patient, who's treating one of your colleagues poorly. How do you interrupt that, kind of maladaptive behavior by that patient who is, in some regards abusing your colleague, for whether it's their sexuality, whether it's their gender identity, whether it happens to be race or something like that. I think it can apply broadly, but what would your technique or approach be to that sort of situation?
Really thoughtful question. I think that, of course, it's going to depend on the intensity of the situation. But things that I've seen are more common examples of if you're wearing a pronoun badge on your ID badge. I've seen patients, and this has happened with me, say, really, is that necessary? Why are you doing that? And that's something that I would categorize as, microaggression, even though it can be pretty intense and make people feel pretty objectified. What I tend to do is simply broadcast my best values or my best intent and then redirect to their care as step one. And that can look something like, this is something small that I can do to make others feel safe. But what I really want to do is talk about why you're here for your procedure today. Redirect back to that. And then step two would be checking in with that person afterwards in a space where their identities aren't mixing, right? The problem with a lot of this is when someone's professional identity is distracted, or the professional task at hand, they're distracted from that by feeling uncomfortable about their personal identity. It's something that's known as identity threat. And I like to keep the patient care moving, try and prevent it from becoming possibly hostile, and then work with the person outside at a separate time to see how they're doing and check in with them in very clear and kind ways. And I think when it comes to this type of stuff has come up with some of the well-being work I do. It's really important for me to tell people quite clearly that here in our department, we're with them and we see them. And we recognize that when something like this happens, it makes them feel like they have to leave part of themselves at home and that that's unacceptable. I'm very clear about making them not feel invalid and making it known what our values as a department are. I think I have a lot more to say about that question, but I don't want to take up too much time. So that's kind of my initial reaction.
That's great. I actually really like your approach to not just making it about an individual, but, that we're working to make it safe for everyone. And, that's why these approaches are taken. That's great.
Yeah, I think one last thing I'll quickly say is we live in an intersectional world, and a lot of this stuff is quite complicated, and I think recognizing that complexity can be very helpful.
Did anybody, any other colleagues here had any thoughts about that? Or, what if the person kind of making these sort of comments is unfortunately not a patient, but maybe one of your colleagues, making similar sort of comment, making unfortunately negative comments about another colleague or about a patient who comes in? What's a great way to interrupt that sort of behavior then?
Yeah, I think that's a great question, and I couldn't agree more with Elliot. I think my approach, I think one of the really critical parts is kind of the timeliness of kind of this interruptive behavior. I think it could be really easy to kind of just put things on hold and then maybe try to circle back later. But I think for both kind of the aggressor who may or may not actually know that they might be making someone uncomfortable, as well as kind of the victim and bystander, that it is really important to kind of call out microaggression or overt aggressive behavior as they happen. And I really like the approach of, instead of kind of saying, I think you are making somebody uncomfortable, I like the approach of just saying, I feel uncomfortable with what's going on with the situation, and not to project anyone else's feeling, but to express my own my own emotions. And oftentimes I will follow up with kind of just asking more questions, like, what did you mean by that? I wonder if this is, perhaps this is what you meant, and maybe it came out another way. And I think it kind of turns it into a really unique kind of teaching and learning opportunity.
That is a very good point, Paul, of kind of like the timeliness of kind of addressing, these things, because it truly makes a difference, right? I think it's important for us to respect each other, and that scenario, I think, is very timely. I've got to say that, in my experience, I haven't, seen a patient having, kind of disrespectful comments towards them, but I've taken care of a patient who has said, thank you so much for, for taking and really seeing me for who I am, because that's not what I've experienced, in the past. So, I think, that goes to show a little bit of the, the visibility and making the patients feel, accepted and safe.
It does seem like in many circumstances, opening a dialogue, Kiki, like you pointed out in your slides, approaching these situations with a growth mindset, just sort of always acknowledging that we all have room for improvement. We're all going to stumble along the way, but that we can hopefully kind of get better along as we go. With that growth mindset and, conversations that you might be having, either with your colleagues or, members of the LGBTQ community that come in, as you attempt to kind of grow, are there questions that you think are best not asked? Things that just you have no business talking to people about, things like that. I think, Hamza, you maybe address that a little bit too in your slides.
What I can think of is going back to Dr. Higgins' point of, stickers on badge and, pins on scrubs kind of thing. I think that opens the opportunity to have conversations with people before it even gets to the point where they say something inappropriate. I think, making that, having that as a symbol to allow people to have conversations with and educate them as to why you're wearing this, and teaching them something that they don't really know, I think opens up the door for education and, clearing up whatever misinformation they have before they actually say it to someone, a colleague or a patient.
If I can tag on one more thing just to the end of this. I put on my like well-being hat for a second, all of this is so for me, it's so important that within a department or within teams, people who are in leadership positions are made aware of all of this. And whether you call that leadership coaching or training, if someone doesn't have that awareness, it's really important to help create these spaces and these teams that are truly belonging and foster that sense of acceptance. In the workplace, I think what's really particularly toxic is if someone feels unsafe as themselves because of perceived opinions of their colleagues or their coworkers. In anesthesiology, we do things that are very high risk. In acute pain medicine, we do things that come with them some risk. And if you're trying to operate at a high level of executive functioning in a situation that's tenuous or critical, and you're not feeling like you can call for help, trust your colleagues to have your back, um, all of these things which are just so critically important to us doing our job well, it's quite risky for someone in terms of feeling like they're a part of a team. And that's why one of the themes in the data is that risk for leaving their current employer, that risk for leaving their training program. If you look at this data, it comes up again and again and again. And my hypothesis is that a lot of it has to do with people not feeling like they can show up to work as their whole selves. They're leaving part of themselves at home. And it may sound like a catchphrase, but to me, what that really means in real life is when they're in these critical moments in the critical work that we do, someone may not feel like they can actually operate in a safe manner because they don't feel welcome. And so I think that's why it's so important to have these conversations and to really open people's minds to the fact that this inclusion work is inextricably linked to well-being. It's so critically important. And so I just wanted to point that out, that I think having these workplace discussions are so important, especially when it comes to relationships between coworkers.
All right. Well, I think we've reached the end of our hour. Dr. Su, Dr. Higgins, Dr. Nin, Dr. Ramawad, thank you so very much for taking the time to come through and, kind of teach all of us, how we can be better advocates for our colleagues, for our patients. It's outstanding. Couple other things coming up: registration for the 49th annual Regional Anesthesia and Acute Pain Medicine meeting, which is taking place March 21st to the 23rd in San Diego. That is open, and if you wanted to be able to get that early bird registration rate, that expires on February 8th. The hotel reservation system is also open. Again, act quickly. You don't want to not have a hotel room. That closes February 23rd. Abstracts are open for the spring meeting as well. The deadline for that is rapidly approaching, Thursday, December 21st at 11:59 p.m. Eastern Time exactly. And then registration is now open as well for the Introduction to Perioperative Point of Care Ultrasound POCUS course, which is going to be held in Scottsdale, Arizona. So with that, thank you all very, very much. On behalf of Azra Pain Medicine, again, thank you for participating in our event. That concludes today's program. Thank you and have a pleasant evening.
Thank you, Dr. Schroeder, for having us.
Thanks, everybody.
Yeah.